Welcome everybody to the October edition of the Southwestern Sydney Health Beyond Showcase seminar series. I'd like to begin by acknowledging the traditional owners of the lands upon which we meet today. For me, that is the Cabral people of the Great Durack Nation. I remind people that we're on Aboriginal land and acknowledge and pay my respects to Aboriginal elders, past and present, and extend that respect to Aboriginal people here today. This series is presented by the Southwestern Sydney Local Health District and the Ingham Institute for Applied Medical Research. This seminar gives the community the opportunity to support researchers who work tirelessly to improve health and well-being, as well as to acknowledge and learn from our researchers. Today's topic is falls and frailty. There'll be a very short survey of 2 minutes at the end of this showcase session, which you'll be able to access via QR codes or a link. The survey is an opportunity for you to give your feedback and will help us with the planning of the showcase seminars for next year. We strongly encourage everyone to complete the survey at the end of the session. The seminar also celebrates the work of the allied health researchers and follows on from the Allied Health Professionals Day last Thursday, October the 14th. I'm sure you're all aware that allied health play an important part of the healthcare team, working with clients, their families, carers, and the whole health team to support people to achieve and maintain their best function possible. Allied health work across all age groups, from birth to end-of-life care, as well as all care environments, from intensive care through hospitals, care facilities, community centres, and the client's home, school, or preschool. I'm particularly proud of Southwestern Sydney Allied Health staff who have continued to demonstrate a strong commitment to our clients, our community, and the health service. They demonstrate high quality care with an emphasis on patient safety and quality of life. In particular, even more so in recent times, they demonstrate flexibility and responsiveness. During the current pandemic, Allied Health have ably stepped into many new roles and demonstrated the transferability of their skills and leadership capability to any situation. My sincere thanks and congratulations to you all. While it's inevitable that we age, as unfortunate as that is, for many, the biggest challenge we face as we age is becoming frail or falling. It's also often the fear of falling that changes our lifestyles and behaviours, and then that inevitably leads to frailty and indeed falling. Frail older people are at high risk of poor health outcomes, high rates of hospitalisation and mortality. Therefore, it's important to correctly identify people with or at risk of frailty and provide evidence-based interventions to slow its progression. Once identified, it's essential that a multidisciplinary team approach, working with the clients, their families, carers, is used to support people to achieve and maintain their best possible function. We chose this topic for the Allied Health focused event as it is relevant to every profession, from dietitians optimising nutrition and promoting weight gain or loss, physiotherapists and exercise physiologists, working on mobility and strengths, OTs assisting with functional activities and activities of daily living and vocation, speech pathologists assisting with communication and problems with swallowing, psychologists might be exploring mood, lack of motivation and confusion, social workers assisting patients and families plan for discharge and gaining supports at home, podiatrists assisting with foot care, footwear and stability, and orthoptists assisting people to see hazards ahead. Today's Innovation and Research Showcase talk highlights two speakers at different stages of their research careers, who have both explored aspects of this work. At the end of the presentations, we plan to put your questions to our speaker, so please enter them in the Q&A section. We do have something, a mention on chat that they can no longer see the presentation, so if we can just look at that, thanks. Jacinda Choy is our first speaker, and she's a speech pathologist who is currently completing her PhD at the University of Sydney. She graduated with first-class honours and was awarded the University Medal in 2014, a significant achievement. Her research focuses on the management of swallowing post-stroke. For all of us, the ability to eat and drink is not solely about gaining hydration and nutrition to survive. It's very much integral to our social activities and relationships, as well as being a great source of pleasure and comfort. For many, our most treasured memories involve sharing food and drink with our loved ones. For some people following a stroke, eating and drinking is difficult, affecting nutrition and hydration, but also may lead to social isolation. We know that speech pathology interventions are important to help people recover these functions. Jacinda's research involves helping patients regain their ability post-stroke, and in particular, to understand the dose of therapy required to achieve the change. Welcome, Jacinda.
Thank you. I'll just share my slides with you all. All right. So before I start, I'd just like to acknowledge my research supervision team. So Dr. Hans Bogart from the University of Sydney, Dr. Freshta Porkazemi and Dr. Roxana Pebdani from the University of Sydney, and Dr. Caitlin Anderson from Braeside Hospital. So as just mentioned, I work as a speech pathologist at Braeside Hospital, and it was a clinical question that led me into doing my PhD. I'm by no means an expert, but I would love to share with you guys today some of the things I've learned and have been doing in my research. So we'll start off with the topic of today, which is frailty. And I'll let Professor Sherrington talk to this more in her presentation. But just briefly, frailty is a complex syndrome that's associated with a progressive decline in physical, mental, and social functions. This results in reduced reserve and an increased vulnerability to deterioration. Frailty is frequently accompanied by sarcopenia. It's a progressive and generalized loss of skeletal muscle mass, strength, and/or function. And sarcopenia affects skeletal muscles, including swallowing-related muscles. And so this can result in dysphagia or swallowing difficulties. Older adults with sarcopenia also might have less teeth, reduced saliva production, poor oral hygiene, and less opportunities for swallowing. And this also can contribute to the development of dysphagia. Dysphagia itself is something that impacts significantly on patients' quality of life, but it also increases aspiration and choking risk. It can restrict the diets and fluids that patients are on and reduces swallow safety and efficiency. And so all of this can also lead to reduced oral intake and the development of malnutrition. Now, malnutrition can affect the mass of muscles. And so in this way can actually lead to nutrition-related sarcopenia and/or frailty. Because of that reduced reserve and frailty, any illness could result in decompensation, and this could cause swallowing difficulties or dysphagia. Older adults with frailty also often have multiple comorbidities, and this also can affect swallowing. And then finally, repeated micro or silent aspirations as a result of dysphagia increases systemic inflammation, and this is thought to contribute to the development of frailty and/or disease-related sarcopenia as well. Further, after dysphagia or aspiration, patients might be nil by mouth or bedbound. And so this too can lead to disuse-related sarcopenia. So as previously mentioned, all of these factors, including frailty, but also sarcopenia, dysphagia, and malnutrition, are all increasingly prevalent in older adults, and they're all independently associated with a longer length of hospital stay, increased healthcare costs, and increased morbidity and mortality. And in particular, frailty, sarcopenia, and dysphagia are thought to be the most significant contributors to hospitalization in older adults. The strong associations between all of these factors are not still fully understood, but as you can see, the complex and reciprocal ways they interact could lead to cycles of deterioration. And thus it's something that's important that we address and consider to improve outcomes for our patients. So I'm going to focus actually on the swallowing side of things and on sarcopenic dysphagia, which is a relatively recently recognized condition. Its diagnostic criteria would have been established maybe less than 10 years ago. As you can see in the flowchart on the right, sarcopenic dysphagia is characterized by whole body muscle weakness, and that's typically assessed by low hand grip strength and or low gait speed, along with low muscle mass, swallowing dysfunction, and the definitive diagnosis of low swallowing muscle strength or mass, which can be assessed with CT, MRI, ultrasound, or with a surrogate measure of reduced tongue pressure strength of less than 20 kilopascals. Now, swallowing involves more than 20 muscles of the head and neck working together in a coordinated sequence. So in the oral phase of swallowing, your muscles such as your lips, tongue, and jaw keep food in your mouth. They help to chew the food as well and to push it to the back of your throat. This initiates a pharyngeal phase of swallowing. And in this phase of swallowing, the larynx moves up and forward. This causes the epiglottis to close over the airway. Muscles also squeeze together to push food through the throat and also to pull the upper esophageal sphincter open. And this allows the food or drink to move down into the esophagus and commences the esophageal phase of swallowing. So you can see how weakness of these muscles would result in swallowing difficulties. So for example, weakness of the suprahyoid muscles pictured here means there'd be reduced upward and forward movement of the larynx. So this would reduce the safety of the swallow, increase the risk of aspiration or choking, and also could lead to more food or drink being left behind in the throat. So adults with sarcopenic dysphagia present with two main complications: reduced swallow safety. So this can lead to choking and aspiration, as well as reduced swallow efficiency, and this can lead to dehydration and malnutrition. However, sarcopenic dysphagia is thought to be underestimated and underdiagnosed. Because of that skeletal muscle loss, patients may be unable to cough, and so aspiration could be asymptomatic or silent. Studies indicate that sarcopenic dysphagia could contribute to around 30% of dysphagia cases in older adults, but the true incidence may actually be different. So briefly and kind of similar to what was just talked about, the interventions for sarcopenic dysphagia are really multidisciplinary, and these are just some of the ways in which the team is involved in intervention. So dietitians are really involved in giving nutritional intervention that aims to improve nutritional status, muscle mass, and body weight. We've seen how malnutrition can worsen sarcopenia and dysphagia, so it's really crucial to be ensuring that patients are having safe oral intake to prevent malnutrition. Further, speech pathologists and dietitians can work together to work on things like modifying diets and fluids and/or enteral feeding. In particular, where it's possible to prescribe oral intake for patients, that's preferable to reduce the amount of time spent meal by mouth, as that can increase the disuse of swallowing muscles. It prolongs hospital stay and also impacts on patients' quality of life. Physiotherapists and exercise physiologists are involved in physical rehab, which aims to reduce bed rest, increase activity, and improve muscle mass and strength, with resistance-based exercises having good outcomes for older, frail adults. And speech pathologists would be involved in doing swallowing exercises. Now, swallowing exercises can be direct, which involve the action of swallowing, such as the Mendelssohn maneuver, an effortful swallow, or specialized programs, such as the McNeil Dysphagia Therapy Program. Or they can be indirect, which aim to strengthen the swallowing related muscles. Given that sarcopenic dysphagia is likely due to the weakness of swallowing muscles, indirect resistance-based strengthening exercises may be most effective. For example, tongue strengthening exercises, head lift or chin tuck against resistance, or expiratory muscle strength training. However, there's limited evidence on treatments for sarcopenic dysphagia. A scoping review that was published just this year found only 8 single patient case study reports on treatments for sarcopenic dysphagia. And some of the typical dysphagia interventions haven't been tested for feasibility and efficacy with older, frail adults. Now, one exercise that has been trialled and may be effective in treating sarcopenic dysphagia is the Shakir head lift exercise. Now, this aims to strengthen suprahyoid muscles, and it involves, as per the picture, the patient lying flat on their back and lifting their head up to look at their toes. In a pilot study with 22 participants, doing this exercise improved opening of the upper esophageal sphincter and anterior movement of the larynx, with all patients progressing to oral intake. The exercise dosage used in this study involved lifting the head and holding it for 1 minute, followed by a 1 minute rest 3 times, followed by 30 repetitive head lifts, all conducted 3 times per day for 6 weeks. Now, this exercise is an effective and commonly used dysphagia rehabilitation exercise, but the dosage of this exercise appears almost arbitrary, and it doesn't match, say, for example, resistance-based dosages. So if the dosage of this exercise was optimized, would its effects be greater? And that leads to a larger overall question on the role of exercise dosage in swallowing intervention, and what dosages are most effective for different swallowing exercises and for different populations. This is really the question that led me into doing my PhD, and it's the topic of our research. So given that there's limited evidence on exercises and dosages for sarcopenic dysphagia, it's worth considering other types of dysphagia. There's various causes of acquired dysphagia, and they include things like sarcopenia, head and neck cancer, neurodegenerative conditions such as Parkinson's disease and MS, stroke, and brain injury. Now, stroke-related dysphagia results from damage to the swallowing centers in the brain, such as the brainstem, and this can cause neuromuscular weakness of those swallowing muscles, as well as other factors such as reduced coordination and reduced sensation. Even though the presentation of stroke-related dysphagia is different from sarcopenic dysphagia, currently the treatment involves similar swallowing exercises, some of which specifically aim to strengthen the weakened swallowing muscles. However, that question about optimal dosages of swallowing exercises still remains. So we conducted a systematic review looking at this topic, aiming to investigate the dosages of swallowing exercises reported in studies of post-stroke dysphagia. So we used a comprehensive search strategy. We searched 5 electronic databases, and this generated, as you can see here, about 3,961 studies. And we included studies where adults with post-stroke dysphagia received rehabilitative swallowing exercises, and where the intervention dosage was described in detail. And 48 studies passed full text review. And overall, we found poor reporting of the dosages of swallowing exercises. So only 26% of the eligible studies actually reported on all 4 elements of the FIT exercise prescription model. That is on frequency, intensity, time, and type of intervention. And secondly, there was significant variation. So 14 different swallowing exercises were reported on, and the dosages of those exercises varied even for the same type of exercise. This was likely due to the fact that, thirdly, there were few rationales for dosage prescription. So just 5 out of 48 studies actually provided an evidence-based rationale for the dosage that they chose. And these rationales are based on, resistance-based strengthening exercise dosages from limb rehabilitation research, or based on principles of neuroplasticity, such as high dosage or intensity. This underreporting of swallowing exercise type and dosage is similar in other dysphagia studies, so including some of those studies on sarcopenic dysphagia. And these findings highlight that our profession still has a way to go in understanding and reporting on dosage of swallowing exercises. So we were then interested how and what dosages are actually reported in clinical practice. So we audited 42 medical records for inpatients with post-stroke dysphagia who received swallowing intervention. And we collected data on the patient characteristics, on the swallowing exercises and dosages they actually received, and on their pre and post functional oral intake score. We also conducted some statistical analysis to investigate the relation between intervention dosage and outcomes. So we found that some aspects of intervention dosage were routinely reported in the medical records. So that included frequency, time, and type of exercise. However, the intensity of swallowing exercises was not consistently reported. By intensity, I mean the amount of effort or energy expended when doing the swallowing exercises. And as clinicians, we're well aware that there's a difference between a patient half-heartedly doing an exercise and a patient putting their full effort into doing an exercise repetition. Overall, we found a mean daily dose of around 20 swallowing exercise repetitions per day. But again, there was significant variation in the exercises and in the dosages used. And insufficient data and the retrospective study design meant that we were unable to determine the relation between swallowing exercise repetitions and swallowing outcomes. So in order to understand that relation between swallowing exercise dosage and swallowing outcomes, in order also to identify some principles to guide our dosage prescription, we're currently conducting an intervention study, investigating if a higher dose of swallowing intervention improves outcomes. It's assumed, but it hasn't actually robustly been shown in swallowing intervention. And so we're recruiting patients with post-stroke dysphagia in an inpatient setting, giving them daily swallowing intervention with a high number of swallowing exercise repetitions per session. We'll be comparing some of the outcomes with a historical control group who received less than half as much intervention. And we're interested if daily swallowing intervention improves functional outcomes, such as oral intake and the rate at which patients improve and quality of life, as well as physical outcomes such as muscle strength and size. So we'll assess the strength of oral muscles using the IOP. So this actually involves pressing an air-filled bulb with the lips or tongue and measuring peak pressure. And then we'll also be assessing the strength of pharyngeal muscles using SEMG, which involves placing electrodes under the chin and measuring the strength of suprahyoid muscle contraction. We're also interested in swallowing muscle size and mass. And does this actually change with intervention and with exercise? And so placing the ultrasound in the transverse position under the chin gives this image. So the ultrasound image you see is actually flipped upside down. So the skin under the chin is actually at the top of the image there. And this allows us to view some of the suprahyoid muscles which are involved in swallowing, including the geniohyoid muscle, the mylohyoid muscle, and the anterior belly of the digastric. And for reliability purposes, we'll be looking at the size of the digastric muscle in our study. And so we're interested if swallowing exercises actually change or improve the strength or size of swallowing muscles. And if so, does an improvement in swallowing muscle size and strength actually correspond to a functional improvement in swallowing and an oral intake? And this will hopefully give us some more information as we think about whether we should be aiming to strengthen swallowing muscles when we're doing our exercises. However, even if a higher dosage of swallowing intervention is better, often a more practical question for our clinical context is it actually feasible? And we're exploring this question through a mixed methods approach. So we've been using student volunteers to increase session frequency. We'll be collecting data on patient adherence to target swallowing exercise dosages. And we're also conducting some qualitative research. So we're going to interview patients to understand what their perspective is on swallowing therapy and on doing a lot of swallowing therapy and what makes it easier or harder for them, as well as conducting some focus groups with clinicians to understand clinician perspectives on high dose swallowing therapy and barriers and facilitators to achieving it in practice. However, as with many things in our time, COVID has posed a bit of a challenge to our ongoing research with low patient numbers, slow recruitment, difficulties accessing some of our outcome measures, and some challenges with face-to-face data collection. So progress has been slow and we're still in progress, but we hope to eventually have some findings that are going to be clinically relevant for clinicians. So what do we know and how does this apply to frailty and dysphagia? So we know that dysphagia is highly prevalent, but also potentially underdiagnosed in frailty. Dysphagia is also significant because of how strongly it impacts on patients' quality of life and how it interacts with things like malnutrition and sarcopenia, which can worsen overall function. So we need to be aware of the signs of dysphagia in order to proactively assess and manage it. What are the signs of dysphagia and what would prompt you to refer to speech pathology? You're probably familiar with some of the signs such as coughing and choking, patient reporting a change in their diet and recurrent chest infections. But the signs of dysphagia can also be more subtle, such as just a change in voice quality, them taking longer to eat or drink, and malnutrition, dehydration, or weight loss. And as discussed, a multidisciplinary approach is needed to treat sarcopenic dysphagia. So not just speech pathologists, but physios, occupational therapists, exercise physiologists, dietitians, just to name a few. And for speech pathologists, when we're prescribing swallowing exercises and dosages, we need to consider the cause of dysphagia and the aim of our intervention. So for example, in sarcopenic dysphagia, resistance-based exercises may be needed to strengthen weakened muscles. However, in stroke-related dysphagia, we may need to combine resistance-based strengthening exercises and dosages with principles of neuroplasticity, such as high-intensity swallow-specific retraining. We also need to consider exercise intensity. So how hard or how much effort is involved? Thinking about our patient capacity, what can they actually do and what's important to them? How do we start and how do we progress? What strategies can we use during sessions, such as how do we word our instructions? How do we demonstrate exercises or give feedback to our patients to encourage them to put their maximum effort while they're doing the exercises? You can think about what tools there are available to measure intensity. So this can help motivate patients, help track their progress and allow us to actually report on intensity. And then also thinking feasibly about how to increase dosage and how do we encourage patients to adhere. And that's a lot of understanding where our patients and our family members come from, educating them on swallowing and what the purpose is of swallowing exercises. It can involve setting repetition targets and setting up routines, trying to be creative with resources, so really getting family members involved, allied health assistants and students. Thinking as well about groups, so patients are getting motivation from other patients or technology such as dysphagia apps, and thinking about setting home exercise programs and being able to monitor with things like tally counters or record sheets. A lot of work has been done, but still more work is needed to improve how we understand swallowing exercise dosages in order ultimately to improve outcomes for our older patients and adults with dysphagia. These are some of the references, and I believe there's a question time at the end.
Thank you. And we will hold the questions to the end for both speakers. Thank you, Jacinda, that was fantastic. And for me, it opens a lot of questions as a speechy. So our next speaker is Professor Cathie Sherrington. Cathie is an NHMRC Senior Research Fellow at the Institute for Musculoskeletal Health in the School of Public Health at the University of Sydney. That's a mouthful. She leads the physical activity, ageing and disability research stream within the Institute. Before embarking on her academic career, Cathie practiced as a physiotherapist in aged care and rehabilitation. Professor Sherrington is an internationally respected expert whose research has made a significant contribution to our understanding of the prevention and management of falls, frailty, and informed evidence-based guidelines that we use in our clinical practice. Worldwide, she publishes the most reviews and papers of anyone on this topic. I've been reliably informed. From a Southwestern Sydney LHD perspective, we've been very fortunate that Professor Sherrington has a strong and long-standing partnership with clinicians in our health district, and several of her large NH and MRC funded research projects have been conducted here, including some that are currently underway. This provides our clinicians and patients with opportunities to take part in these high-quality studies and plays some part in shaping the research evidence. Professor Sherrington's regularly invited to speak on this topic to researchers and clinicians around the world. So I'd like to welcome Professor Sherrington to share her presentation with us now.
Fantastic. Thank you so much for having me, and yeah, thank you for that very kind introduction. And so, yeah, I certainly do have a long association with Southwest Sydney. So most of my clinical work was actually done as a physiotherapist in Southwest Sydney, initially at Lidcombe Hospital and then later at Bankstown Lidcombe Hospital, and yeah, have ongoing collaborations. And so I'm going to actually talk a little bit about some of the studies that we've undertaken and are undertaking in Southwest Sydney, and also talk about some of the work of some other team members who have also come from Southwest Sydney as well. And so, as you're very well aware, we have an ageing population. And so in 1990, only 1 in 17 people were aged over 65. It's now around 1 in 10 globally, and it's predicted to be 1 in 6 by the middle of this century. And so that's why questions of falls and frailty are crucially important to our health systems. So falls are unintentionally landing on the ground or another lower surface, and affect 1 in 3 people each year who are age 65. Well, actually 1 in 3 people fall themselves who are age 65. Frailty, as Jacinda's very nicely talked about, is a decline in functioning across multiple physiological systems and a vulnerability to stresses, and is estimated to affect 1 in 5 older Australians. I'll talk a little bit about falls first and then go on to talk a bit more about frailty and what we can do about them. And so, as I understand it, falls really come from an interaction between the person's physical functioning and their behaviour, but often have an environmental trigger, so such as a trip or slip. And we can then think about what causes these things and what influences these things. So further back, behaviours influenced by cognition, insights, attitudes and distraction. And physical functioning is influenced by disease, medication, ageing itself, and also inactivity that I'm going to focus on. So because of this, many falls prevention interventions have focused on exercise. And so we did a Cochrane review, which actually included 108 trials of exercise for falls prevention in the community. We were able to pool 59 of these and found high certainty evidence that overall exercise reduced the rate of falls by 23%. And turning this into people, if we were to follow 1,000 people for a year, 850 of these would actually have a fall. But with these type of exercise interventions, we could actually decrease the number of falls by 195. So that's, potentially a lot of falls that we're actually going to be able to prevent. So we found that different types of exercise had different effectiveness. So we found that exercise that focused on balance and function with a high certainty evidence prevented falls, as did exercise that included multiple exercise categories, which normally focused on balance and function, but also included resistance training. There was a moderate certainty of evidence for that. And also Tai Chi. Although it gets more attention, there was actually only a low certainty of evidence that Tai Chi prevents falls. So these are some of the exercises from one of the particularly effective programs, the Otago home exercise program that was included in the review. And we were fortunate to get some attention for this review. So I was on the health report with Norman Swan before he had his COVID focus, which has obviously been really crucial. But yeah, so we're really keen to get the message out more about the importance of falls and about the role of exercise in preventing falls. One thing we don't know in terms of preventing falls is whether yoga can prevent falls. And so Anne Tiedemann, who works with me, has secured funding from the NHMRC, and we're running a trial looking at yoga for falls prevention. And a bit of a COVID silver lining that we've actually moved this to being an online yoga intervention. It's being very well received, but we won't know the results for another year or so. To further information about falls, the Clinical Excellence Commission has a great set of resources on their website, and we've got an online conference coming up later in this year from the Australia and New Zealand Fall Prevention Society. And so on to frailty. And so, as Jacinda very nicely highlighted, frailty really is quite complex and involves sarcopenia, also nutrition, and also it does involve strength, but I would actually also argue that it does involve coordination and motor control. And so that's where actually the neural plasticity aspects that she was talking about, I think, are actually quite important as well. Clinically, people tend to use the clinical frailty scale, which gives a really nice kind of pragmatic way of assessing people's level of frailty. And so with colleagues, Ian Cameron and Sue Curl, Nikki Fairhall actually worked on developing and delivering an exercise intervention to address frailty. And Nikki was previously a physiotherapist at Bankstown Lidcombe Hospital as well. And we basically found, a very effective multidisciplinary intervention, and the details of this are in these papers here. And so from an allied health point of view, this is really important because the physiotherapist actually saw everybody and then referred people to see additional disciplines where required. And there was also a multidisciplinary case conference, but there's a lot more details in the paper. But in terms of the exercise aspect, so we prescribed a home exercise approach. People were asked to exercise 3 or more sessions a week. We considered fatigue. We started slow. We focused on functional strength and balance, and added strength training of a higher intensity where this was possible. And we actually managed to decrease frailty, both at 3 months, it was not quite significant, but also at 12 months. And also impacted on gait speed. So basically looking at a deterioration in the control group and an improvement in the intervention group. And multiple other measures as well. This was the goal attainment scale, which looks at participation in community activities, also a between group difference. And as I said, there's more information in the papers. Another one of our PhD students who also was previously a physiotherapist at Bankstown Lidcombe Hospital, Daniel Tracy, also did his some work on this in his PhD. So he's done a Cochrane review looking at mobility training for people with frailty, and this is still under review at the moment. But basically finding again strong impacts of really mobility training and exercise-based interventions for mobility and also for physical functioning. And there's also a lot more resources on frailty on the at the ACI Frailty Task Force website. So to me, both of these fit into the context of healthy aging though. And the UN has recently launched a new decade of healthy aging. They define healthy aging as the process of developing and maintaining functional ability that enables well-being in older age. And it really is a life course approach to this. And so they talk about functional ability as being made up of intrinsic capacity, so the person's physical and mental capacity, and also the environment that they're living in the broader sense, and how that enables their participation. And so they have a really nice model, which to me is, it really helps us think about how prevention and rehabilitation can kind of relate together in this area with a life course approach. And so obviously we would all like to have this trajectory A, where we're actually maintaining a high physical capacity really until the end of life, and then have a sudden decrease. Unfortunately, many people follow this yellow line where they have some type of an interruption. So whether that's an acute illness or an injury, but then that dotted yellow line, we can really look at the role of rehabilitation in trying to return people to that high level of intrinsic capacity. And unfortunately, also a number of people have that trajectory C, which is a gradual decline, But that's where we can also look at interventions and ideally sort of prevention type interventions to really try and improve that, that physical capacity. And so the World Health Organization new guidelines on physical activity and sedentary behaviour now do a better job of actually recognising how these things work together. And for the first time, these guidelines actually mention falls and physical capacity or functional capacity. And they talk about and they apply to people living with chronic conditions and also people living with disabilities. And so they're basically recommending that people undertake moderate to vigorous intensity physical activity and also undertake strengthening exercises, and also as part of that physical activity undertake multi-component exercises which emphasize functional balance and functional strength. And so that comes on to that, that coordination, that sort of plasticity approach. Unfortunately, most people don't actually do this. So these were the previous guidelines where across all adults, so this is people meeting 150 minutes of physical activity. Across all adults, only half of Australians do that, and only a third of people aged over 75. Even fewer people do any strength training, and even fewer people do both. And so we really need to work out how to get from this situation of what the population currently does towards people meeting the guidelines and getting those health benefits. So the World Health Organization also provides this really nice model for how these things can work together and how we can increase physical activity across the globe. And so they talk about 4 different aspects. So the first one being active societies. So we need changes to social norms and attitudes. And to me, ageism sort of falls into there as well. We need active environments. We need places and spaces in which encourage people to be active. And we need active systems. So we need governance and policy that actually supports people to be active. But then probably where health most intersects with is active people. So providing programs and opportunities that support people of all ages and physical abilities and health to be active. And so to me, both health and community services can be providing effective programs and interventions. And that health professionals can have a role in delivering programs, but also in promoting programs and referring people to community programs, because obviously we don't have the capacity to deliver such programs in health. But I think we do need better interfaces between health and community programs. And so to further guide what to do about this, my team was actually commissioned by the World Health Organization to do an evidence review about physical activity programs and services for older adults. And so this is quite busy, and this will be available later, but this is to inform an upcoming toolkit. And these were high quality, large scale trials. And we can basically see from these, so all the blue as opposed to white are where the trials, more than half of the outcome measures showed an effect. And so basically there's effects from all different types of physical activity across all different outcomes. And it basically did also apply in different settings and different populations. But then we need to work out ways to actually develop those into programs that we can deliver and offer to people. And we need to understand the effectiveness of different programs in different populations. So I'm now just going to go through quite quickly, but some different ideas and different programs that we've been involved in developing and evaluating, often in Southwest Sydney. And a lot of this focuses also on kind of efficient ways to deliver programs and basically ways of getting health professional input that doesn't involve a lot of face-to-face supervised intervention because resources are limited. And so we know that using activity monitors can improve physical activity in older adults. This was from Juliana Oliveira in our group. We also know that health coaching can have a positive effect on physical activity in older adults. And so we've developed a coaching intervention that also incorporates physical activity monitors, so pedometers, or really Fitbits in the more modern versions. And the coaching is actually delivered by physiotherapists. And so this to us is a way of efficiently providing physiotherapy intervention to large numbers of people in the general community. And we don't have the results finished yet, but they're really quite positive in terms of the role of coaching to improve physical activity. And we have asked people, we've done qualitative work looking at what people think of the intervention, and it's been extremely well received. And also the fact that it's physiotherapists delivering the intervention has been very well received by the older adults. We also need to start earlier. And so this is another of our PhD students, Geraldine Wallbank, who actually also developed an interest in research while working at Bankstown Hospital. And so she's developed some scalable programs that target middle-aged people. And so there's one program that involves workshops and a single workshop and a website, and another that involves more sort of tailored access to information and a single coaching session. So to me, these are also really quite promising interventions that are ways of efficiently delivering health professional input to large numbers of people. Taking this coaching approach further, we are doing the comeback trial, and here there's a large Southwest Sydney link as well. So we're recruiting from hospitals in Southwest Sydney. So yeah, you're very welcome to refer patients to this. It's led by Leanne Hassett, and Siobhan Wong is doing her PhD on it as well. And Siobhan's a physio at Liverpool Hospital, and Leanne previously worked at Liverpool and has continued her association with the district. And so this, and Matt Jennings is one of our investigators as well, and has been really crucial to the study in terms of developing the intervention in a way that could be scaled up and delivered more extensively. And so this again involves coaching from a physiotherapist, but focuses on people with mobility limitations. And it has a big focus also on referring people to community exercise, as well as using activity monitors where able. And it's really a person-centered sort of approach where we're working with what the person's up to, where they're at, how active they are, and really trying to move that in a way that works for them, fits with their disabilities, and is achievable. So this also builds from another study that we undertook, also at Bankstown and Lidcombe and Liverpool hospitals, the AMOUNT study, also led by Leanne. And also involving Siobhan and many other clinicians as well. And so this was using technology to increase the dose of exercise intervention. And again, using that sort of task related and the sort of plasticity aspects of really trying to have people practice and really use the technology to help get as much activity as is possible. And that found on the short physical performance battery, which measures the ability to stand up, walk, and standing balance, found a marked separation between the groups, both in the inpatient phase, because people were recruited as inpatients, and also following up at 6-month follow-up. So again, an efficient way to deliver an intervention. Similarly, in terms of efficient interventions, Daniel Tracy, when he was at Bankstown Lidcombe Hospital as well, developed and delivered a circuit class, which was again a way of efficiently increasing the dose of practice within inpatient rehabilitation, and found that to be effective in improving standing balance, but also actually cost saving in an economic analysis because of its impact on length of stay. We've also done studies that have looked at referral so people who've been in hospitals and delivering a home exercise program in visits from a physiotherapist. And this was our web intervention, which again focuses on those sort of functional exercises, standing up, stepping, balance standing. And again, we had a marked improvement in mobility, already not quite a separation at 3 months, but by 12 months, a separation between the groups. So it really does indicate that we need sort of ongoing behaviour change. With this one, the close readers will see that unfortunately we actually increased the number of falls. So we do need to be building in falls prevention advice when we're dealing with frailer people and higher risk people. And in this study, the Restore study, we did actually build in the falls prevention and safety advice as well as the home exercise program. And this was in people who'd had fall-related fractures. And here we were able to also increase functioning without increasing falls. We also increased people's independence, so they reported needing less help with daily activities. But then we really need to work out how to actually incorporate these interventions better into our clinical services. And so we now have a program of work where we're working directly with clinicians to try and incorporate these interventions better into practice. And so to understand how to do that, we need to actually ask clinicians what they think and what they're currently doing. And so over the last couple of years, we've done surveys and also focus groups of over 200 physiotherapy clinicians to really find out about what they're doing with promoting physical activity in their daily roles. And they all considered that promotion of physical activity was part of their roles. And around 62% were actually already discussed physical activity with 50% of their patients. But they did identify key barriers, so particularly competing priorities, limited time, limited skills in behaviour change, and limited knowledge and existence of suitable opportunities. And so this was a survey that was done in Southwest Sydney, exploring that in more detail. And now Leanne's leading the behaviour trial, which is working directly with physios in Southwest Sydney to assist them to incorporate physical activity counselling into their daily practice. It's obviously a little bit on hold at the moment due to COVID, but hopes to get fully up and running next year. We've also done Kerry West, another of our PhD students, who's the head physio at the Children's Hospital at Westmead, has done sort of further interviews with physios across adult and paediatric settings to look at developing further interventions. We also have a Centre of Research Excellence in the prevention of fall-related injuries, and we're really keen to do more of this type of work, working with clinical services to work out how to best incorporate these types of interventions. And Matt Jennings, again, is involved in this and is crucial in that. So that was a rapid run through some different projects. I'll just leave you with some additional resources. So this is the Safe Exercise at Home website that we developed to help prescribe home exercise and help promote exercise to older people. We also recently hosted a webinar, and the information's available from that. So lots of stories about how people are staying active at this difficult time, and what that people can do to help, and what resources are available. So then, by way of conclusion, we know that falls, frailty and loss of physical functioning will continue to grow in the impacts on health systems due to global ageing, but that physical activity is very powerful in prevention and rehabilitation. But we really need researchers, health services and multidisciplinary clinicians to work together to be able to generate, implement and test solutions to this. And just like to acknowledge funders, collaborators, staff, students and study participants. And that's where to find me if you'd like to talk more about these. Oh, and this is my attempting to influence the social norms. So sharing the photo of me doing the city to surf when that was a thing, which hopefully it will be again, and slowly but having fun. So yeah, thank you very much for your attention.
Thank you, Cathie. Now, there are a number of questions about where we're going to share the video and the slides and the links to the exercise program at exercising at home and all of that as well. We will share all of those to our participants, and the video is also going to be a YouTube video of the recording of the presentation, plus it'll be on the Beyond Health website as well when it's finished. Now, we do have a couple of questions for each of you. So Jacinda, if we start with you, and we might mind you to take yourself off mute to answer. So the development of aspiration pneumonia is as much dependent on poor cough as it is on oropharyngeal dysphagia. Are any strategies effective in improving cough effectiveness in frail patients?
Yeah, that's a really good point. Definitely aspiration doesn't immediately result in aspiration pneumonia, and cough is really important. There's kind of two main aspects to cough. There's the motor side of it, so having the muscles and the strength to be able to cough, and then the sensation side of it, so being able to detect when there's aspiration and cough appropriately. In terms of the motor aspect of cough, the main intervention I'm aware of is expiratory muscle strength training, or EMST. That's basically a device where the patient blows into it and it provides some resistance, and the resistance can actually be altered. So you can base it on the patient's level and increase it as they get better. So that was originally, I think, used with patients with Parkinson's. That's probably the main intervention for improving motor strength in coughing. And then the kind of sensation side of it is obviously quite tricky, and there's less, intervention available to improve sensation of the oropharynx. But I believe there's some great research on cough reflex testing that's coming out from kind of New Zealand. So you could definitely have a look into that.
And I think we will be sharing, if people would like to be in touch with Jacinda, then you can certainly contact us and we will put you in touch. Cathie has shared the exercises in the chat if you want to have a look at that as well. Cathie, so falls and hospital-acquired frailty continue to be a significant hospital-acquired, health-acquired complication. So from your research, what lessons should we be considering in designing our models of care whilst patients are hospitalised so that they don't end up worse off than they came in?
That's a crucial question. So yeah, thank you very much. And that's where, again, I think we really need collaborative approaches to sort of developing feasible interventions and working out ways that we can kind of incorporate that into our stressed health system. But yeah, obviously something that is, totally crucial. And that's something John Ward, a geriatrician, speaks very passionately about that, because yeah, unfortunately, people do often deteriorate while they're under our care, and so we really do need better ways to deliver those interventions.
Jacinda, the inclusion of exercise dosage as part of the rehabilitation program is acknowledged as very important. So how can we support independent exercise given the challenges of repeat visits by the therapist in hospital, or ability to continue exercising once discharged?
Yeah. That's a great question. I don't have any easy answers to it. I think kind of the first part of that question was for inpatients and how to actually increase the frequency of us seeing them. Obviously, that's limited by staffing availability. In our study, we actually got some students to come in, and it was surprising how many students are really keen for that opportunity to come in and provide intervention to patients, because they wanted more experience, and it ended up being a really great way to increase session frequency. So again, using students and potentially allied health assistants. But then the other aspect is, wanting patients to practice more independently. And so using family members, a lot of education and help. The other thing that we found is that we use in our rehab hospitals having record sheets where the patients actually tick it off. And we got this actually from our physiotherapy colleagues, like having tally counters where patients can actually use a tally counter and count how many repetitions they do. So maybe just some simple strategies, but definitely something we need to keep working on.
Okay, and I think there was a suggestion here that other service-related outcomes could be included in your study, such as length of stay or occasions of service.
Yeah.
And a question about when your research is due for completion.
Thanks for that. That's actually a really great point about including some of those service-related factors. So we will be collecting that and trying to work out, I think, when we get our data at the end, how to analyze and bring all of that together. But that's a really good point. So thanks for that. And in terms of when we finish, our data collection period was supposed to finish May next year. Unfortunately, it's a little bit pushed back. It depends how many participants we get, but hoping for the end of next year when we kind of have all the results together, or maybe early the year after.
Okay, and one last question, because we're just running out of time. But the other questions we will keep a list of, and we'll ask Cathie to answer if she could. But there was one here about how we can increase or work with the local government councils to increase funding for programs being delivered in the community by the councils, particularly for those people who don't have access to computers, and how we can get some community hub funding to increase activity programs. Quick question, I know.
I think that's a crucial strategy, and again, something really to work together on, and really benefit from partnerships, and to be having kind of clear like referral pathways between kind of community activities and health. And
Now,
we do have some further work in that area that we're hoping to do.
Righto. And I will pass on these other questions to Cathie, and hopefully we can share those answers for you. Just so because we have run out of time, just finally, we will share the link to everybody right now, if we could, for the QR code. Wonderful. For those of you that have a phone ready, you can hover over the QR code, or you can copy and paste the link and give us some feedback for future presentations. I'd like to thank you to both Cathie and Jacinda for your wonderful presentations. They've certainly opened a lot of thoughts for me about what we can do in our facilities and our community services, not just for acute care, but also our chronic and our care in the community, to try and keep people away from us, and encourage you to continue to share in your research journey, Jacinda. We look forward to you with your further results, and thank Cathie and for her ongoing support of research in Southwestern Sydney. Thank you, everybody.